Huh?
That's what Max did. He extubated himself. Let's say we put it in because I don't want to mess it all
If you
up.
just rip off the pilot balloon, it takes a while for the air to go out. Don't shortcut, take your syringe.
So we got this, we got this, we're gonna suction.
Okay, if you have everything and everything's checked, let's get going.
Let me know. You're in charge.
Can you
Take
see?
'em up. So we're gonna suction everything good, and then we will intubate.
Don't break his teeth. The tube is 24 at the teeth. Come on.
Don't let go of the tube.
Yeah.
Hold
the tube.
Hold the tube.
All the tube. And then
Good job, 30
Color
seconds.
change.
so we're gonna verify, listen to both sides on the
You
trach.
listen here.
Well, first of all, we're gonna listen, like, if there's flow by the thing, like, we're gonna listen on the trach and listen to the lungs, like, if there's airflow both, and if there's no leaks around the cuff.
Okay. So, what else are we gonna do?
And then we're gonna secure it too.
X-ray. We're gonna order chest X-ray.
Missed something. On the
There's
table.
Say what?
Oh,
Your left hand.
You got, like, number for here.
No, this is it?
Yeah.
Yeah, but your ambu bag is not gonna automatically have that on there, so you wanna go through the,
Okay. And then we're
putting it
gonna
on.
verify. Verify.
Okay, get disconnected.
Down, you just pull it off. Yeah.
I know. Okay.
Good color change. Okay, it's a stomach, no color change.
I don't think any carbon dioxide is coming out of this.
Yeah, that's
Okay,
the
so you put the tube in, what are you gonna do now? Tell me all the steps. No. So we got color change, what else?
thing. Okay. So we'll listen,
Okay,
and then, like, if everything's good, we're gonna secure the tube.
what else are we gonna look for?
Don't come in over for it.
Condensation in the tube,
Chest rise.
chest rise,
Saturation.
and listen over the belly. Make sure you don't hear anything over the stomach. So, color change on your end title,
Bowel sounds.
condensation,
There's bowel sounds.
gurgling like my stomach because I'm hungry.
Yeah.
Chest rise, bilateral breath sounds, and make sure you don't hear air over the stomach. Okay, so that's in order X-ray. Now what?
Order X-ray.
Secure the
Secure
tube.
the tube.
Secure the
I
tube.
already said it. Okay. Then we're gonna. Ooh, disassemble this whole thing.
No, you could say it was just to, they had 30 seconds to do this.
He did.
He did.
Oh, he did?
Oh, I didn't see it.
Ms. Foster, so is X-ray usually on standby when you're in the code?
No.
Because they won't actually come to take X-ray unless
They
the
order,
patient
like,
is
everything.
revived and intubated and all that.
So in that, the whole time you're just holding the tube while X-ray comes?
Well, if you bring the patient back and you're like in the ER, you'll put them on your transport vent. But sometimes you might just be there bagging like the patients who you couldn't put on the vent because they were desaturating. So you could bag somebody for 4 hours.
Should we?
We would be usually the ones to bag.
Who else is gonna bag?
The volunteer.
Volunteer, that volunteer.
ER tech.
Family member.
We need your help.
One more family member.
No.
Hold on, it's like,
What
it's,
is it? No, I think
it's-
understood.
The other way.
There we go.
It's like-
There you
You
go.
guys
Put
need to
this
practice
thing-
using this
This
Hollister
inside and then you
Yeah.
lock it.
and taping, which I came around and showed everybody last week.
we got it.
There we go.
From the first strike, right, Max?
Don't put it on his head. It's about being on his ear.
Well, we're gonna put it behind.
All right.
Yeah, I had, like, they tested me,
Here,
like,
this is not-
whether, how fast you're gonna, bag a patient.
Yeah, how fast are you gonna bag a patient?
Always doing
It
fine.
depends.
Every 5 to 6
I'll
seconds.
look on his PA, like his sets. If his sets are low, we're gonna bag him faster. Because in our code, we're bagging him like
Did you input the
per,
code?
like 24 or more breaths a
Instant.
minute. Yeah, where we go like this. Because
Yeah.
her sets would drop. But like when she gets her sets normal, I'll breathe like 12, 15.
Right, and then don't forget you can put a PEEP valve on here, so that if your patient's sats are dropping, you could put a PEEP valve on here. It actually goes where this is. Have you guys seen the PEEP valve yet?
No.
No,
No,
I
I
so
see
let me
it.
go grab it real quick.
Close it before it gets hot.
Say what?
Close it before it gets really hot.
Okay, extubate. Oh, she's not here.
Good job, guys.
I totally moved over.
Let me have this one. So whatever amount of PEEP they are on the vent, the PEEP valve should be on the ambu bag dialed into the same amount of PEEP. So, and I'll teach you something tomorrow that you can do if your patient is on very high levels of PEEP. If you unhook the ambu bag from them, or excuse me, or the circuit, either one, then what's gonna happen to all that PEEP? You guys saw it last week when I showed you the big ones. So there's a technique you can use to help keep the PEEP in and prevent the loss of all that PEEP, which we'll talk about tomorrow. So this is a PEEP valve. They all look pretty similar to this. And this dial, you're just gonna turn it down to the level of PEEP that the patient is on the vent. Especially higher amounts of PEEP over 10, very, very important. So part of what you should be doing is if your patient is on PEEP and you're coming in to do your check your ambu bag, make sure you have a mask and make sure it has a PEEP valve on it dialed into the amount of PEEP that your patient has. So, and I'll pass this around, you can just see there's a black line and you just twist this so that the bottom of this is on the black line at whatever amount that you want. And then it's gonna go onto the ambu bag like that.
On our code sheet, the respiratory therapist should actually put 12
Well,
PEEP on the.
And that's where I was headed, was even though we don't typically use them in a code situation, if your patient is doing very poorly and desaturating, like the patients, some of the ones that you guys were talking about, you will get someone to get you a PEEP valve and put it on there because it will help during the while you're bagging them. So here's the Ballard. So this guy's intubated. I'm gonna go into extubation, so I don't know if you guys are just gonna video or if you wanna get your notes that were up here. Thank you for your help.
Here,
Good job.
thank you.
Take the CO2 off. Now, for our purposes of transitioning from being intubated to the ventilator, we're gonna put the Ballard on, our tube. And this would be hooked to, where's my little piece of, the vent circuit. So you need this short little piece of corrugated tubing which goes onto the T piece on the Ballard, and then your vent circuit goes right here. So that's how that's all gonna be attached. So Ballards have two different lengths. One is made for an ET tube and one is made for a trach, and it'll actually say that on the package. So the ET tube is this one, it's the longer one. The trach is much shorter. So be careful, because you could use this on a patient with a trach. You just need to be very careful so that you don't put it in too far.
14 French.
This one?
Yeah.
No, this one's not a trach. Look how long that is. This one is a trach.
It's also a baby.
Yeah, but you can still see it's a lot shorter. So see, this is a trach one. So this is a lot shorter. Well, this is a little different, but that's a trach one. This is the ET tube, so it's a lot shorter. So just be careful. If you do have an ET tube size one in your patient's trach, be very careful so you don't go in too far. You need to make sure that you guys practice. How many have done anything with a Ballard? Just a handful of you. So while we're working on lab today, which will be after our break, you need to put Ballards on here and practice doing this, because this is weird when you're not used to it. Suctioning with the Ballard through the sleeve here. So what you have to do, so a couple of things that are important to this, you have to make sure that you get your catheter all the way out and it's not sitting in the ET tube like this. That's not going to be good. It's not supposed to be here, here, here. It's supposed to be all the way out, so this black line should be past this part right here. This part locks, or is right now, it's in place so that I can suction, but when I'm done, I need to turn it like that so it can't be pushed. Your suction tubing, you take this cap off, and it's going to go right on here. Yep. Like this. And then they have little stickers on here so that you can put what day it needs to be changed. I think they're changing them every 3 days, most places. They've done a lot of studies that show that Bellards don't need to be changed as often as people change them, but I'm not sure how much that's changed in the clinic setting. So obviously if it's soiled and yicky and patients have lots of secretions, or patients with really bad pulmonary edema, you're gonna have that pink frothy secretions everywhere. If you haven't seen it yet, you will. So it's very common to get water just sitting right in here in this part. A lot of times people try to take the suction just in right here in this little amount and try to suction out any water that's hanging out in there. Sometimes you can, sometimes you can't. Because if you think about what I was just saying, even if you do this, but you can take this cap off, it's usually much easier to do than this. If it is, it usually just comes right off.
Guys, help her out.
Here, you can get that off. There we go. You see? I told you it's much easier than that. So this cap will come off, and then you can drain the water here. So what a lot of people do is they'll get a towel, and there's water that collects in here. Get a towel, and then open the cap, and then let the water out, and then put the cap back on. Now that's only if it's a lot of water. If your patient's on a lot of PEEP, though, you don't want to do that. So you'll have to try to drain it another way, or do what I'm going to show you tomorrow and just take it off and drain it. So otherwise, when you're suctioning with this, the trick to it is to push the catheter in and don't move your hand, and just let this clear plastic covering slide back. In with the suction, back, in, back. So see, I'm not moving my hand at all. I'm moving the suction catheter. So in and then back, and then in and then back. So it's going to keep going like this. And sometimes you need to hold it up straight. And so you'll get good at it, and you'll be able to do it really fast like this, because you know you don't want to take more than 15-20 seconds to suction. And then once you get it in, your patient starts coughing, you can pull back and pull it all the way back to suction out. There's a little port here. You can squeeze saline, put saline in here, and at the same time suction, and then the saline just goes right through the tube to clean it out. You always want to do that afterwards. So while you're practicing today, because you're going to intubate, you need to practice with a Hollister and taping, like I showed, because you guys need to be able to use these Hollisters as well. And then put the Ballard on it, because the Ballard's going to signify that we're on the vent. Use the Ballard and practice going down like this and getting used to it. And then we're going to go right into extubation. So, okay, so our patient's all better, and now he needs to be extubated. So as far as supplies go, technically you need re-intubation equipment. So if something happens and your patient needs to be re-intubated. So for purposes of the classroom, we're just going to verbalize that I'm going to get re-intubation equipment. You're not taking re-intubation equipment and bringing it into your patient's room. It's going to freak them out. You're taking the tube out. They don't want it to go back in. So, but, you know, we could think that our patient's going to do fantastic. We're going to take our tube out and we think everything's going to go great, but it doesn't always go great. So you always have to be prepared in the back of your mind, thinking that you might have to re-intubate. So of course in the ICU we're going to have our crash cart that we could go grab if we needed to. But you need to have your ambu bag and your mask. Again, we don't need to put this right on top of the patient to freak him out that things are going to be happening. Huh? Oh, okay, Joe, we're going to have this here just in case we put the tube back in. No. What I normally do is put this behind like his pillows. You got, so that he doesn't know it's really there or really what's going on, but I have it back there just in case I need it. Because don't think that you might not get an emergency re-intubation after extubation. It happens, and so you need to be prepared. So go ahead and have your ambu bag and mask just back in the back where it's somewhere you could grab it if you needed to. So re-intubation equipment, ambu bag and mask. We need a syringe so we can take the air out. We need a towel. Can someone grab me a paper towel? We'll just use paper towels for our purposes. Thank you. The towel's gonna go here. Most people use like those blue check things where the shiny side on the one side, because when you take the tube out, you need somewhere to put it. You don't want to put his disgusting ET tube on his gown or his blanket or any of that stuff. Of course, you need your stethoscope. You need this stuff is already going to be there, but you have to verbalize it for me. You need your yank hour suction. Of course, we're going to suction here. What was the other thing? And then you need whatever O2 you're going to put them on. So a lot of places are going to nasal cannulas. I think it's because people are being lazy. I still believe that a cool aerosol mask is the best thing for a patient to be on post-extubation. It's what we used to do for everybody. Nice, cool oxygen and moisture coming into an airway that's probably a little bit inflamed. Whether you do it or not is going to depend on where you're at. But the CAM can just go on whatever FiO2 your patient was on when they were on the vent. So say they're on 35%. You can put it on a 35% CAM. Some people, most patients are on 5 a peep when they're extubated. So some people would say, well, they probably need a little bit higher. Well, they probably don't because we're extubating them, but some schools of thought will be that you would do the FiO2 they were on plus 5% for the 5 a peep. So it would be, if they were on 35 and 5 a peep, they would do 40. So just so you're aware of that. I'm fine with you just using 35. So you guys remember the CAM setup, the bottle, the tubing, and then a mask, an aerosol mask. Now this is going to be short term, so we don't have to worry about a reservoir bag. Because it's just going to be a short-term CAM. So we're not going to worry about collecting the water or anything. All we need is our bottle, our tubing, and our mask. So I know that everyone in here can put a nasal cannula on a patient, but I like to see that everyone remembers how to set up a CAM. So for our extubation, for our checkoff, you're going to put them on a CAM and actually do that so that I can see that you can do that. So you're going to have that ready to go. And then the last thing you need, in a real hospital setting, you're not going to have racemic epinephrine in your pocket. You obviously have to get it out of the Pyxis if you need it. But we need to verbalize that we need to have racemic epinephrine on standby in the event of stridor. What's the dosage? You guys are so good. 11.25 milligrams given by aerosol, so SVN. If your patient has stridor and you're giving them an aerosol treatment, they're probably going to use a mask. So this is the thing with stridor, which happens post-extubation. Sometimes we might be prepared for stridor. Sometimes someone goes into stridor and you had no idea it was going to happen. So we have mild to moderate stridor, and then we have what's also known as marked. You're going to see that word, M-A-R-K-E-D. And if you see the word marked stridor, think severe. It's what they're talking about. Very bad. So mild to moderate stridor, you may not hear it audibly. Anybody in here actually heard stridor yet? It's kind of hard to explain. It's this loud, obnoxious sound that's coming from somebody's upper airway. You'll know it when you hear it. So you may not, you usually can hear stridor without a stethoscope, even mild stridor, but if you're not real close to the patient, you might not hear mild stridor. So when we're done extubating, we're always going to listen over the trachea because we want to listen and see if we hear stridor or not. Stridor sound is very upper airway, where wheezing is more lower airways. So if you hear it up here, it's more than likely it's stridor. So, and it's this really high-pitched, obnoxious sound as well. So mild to moderate stridor, patients need to be on a CAM if they're not on one already, and they need a treatment of racemic epi. So that's going to be what you're going to do for mild or moderate stridor. So your patient's in a little distress, you can hear it over the trachea, or you can audibly hear it. But your patient has air movement, which is a very distinct difference between that and marked stridor. So you'll be able to hear air movement, you'll be able to hear breath sounds, things like that. SATs will probably be okay. Like I said, your patient will just be in mild to moderate distress. Marked stridor is a total different situation. It's an emergency, it's very severe. Your patient will look scared to death because they can't breathe. So you're going to see a patient who is struggling and doing everything I can to get air in through their vocal cords, and they pretty much can't. So you're going to see someone who's like exerting all of this effort with no air going in a loud, stridor is sound. SATs will be bad, the accessory muscle usage will be very, very high. You'll see extreme distress in your patient. What are we gonna do? Do you think your patient has any air movement?
No.
Do they have time for racemic epinephrine to work? Mm-mm, they need to be re-intubated. So, common mistake that people make on the boards, this is what I'm gonna tell you, is that we see marked stridor and we got a patient on our test. The patient is experiencing marked stridor, blah, blah, blah. They're gonna tell you all this and then they're gonna give you some choices and it's gonna say bag, mask, ventilate. And then it's gonna say re-intubate and it's gonna say give racemic epinephrine, put them on a cam. Everybody wants to pick the bag, mask, ventilate. Because they think they need to bag the patient and wait for someone to get all the re-intubation equipment. I understand that line of thinking, and this is kind of along the same line of thinking as when you see VFib, you defib. It doesn't mean clinically we don't start CPR. While someone goes and gets the stuff to defibrillate. It's a concept question. They want to see that when someone's in VFib, you know that they need to be defibbed more than anything. That's your main priority. Same thing here. Obviously, if someone's in severe stridor, we have to go get the re-intubation supplies. Someone needs to try to bag them. So I'm not saying that. But the problem is that bagging going to be effective? No, it's not. This is a horrible situation to be in. It's very, very scary. It's a very high stress situation because you basically have a patient who's going to die on you if you don't get them an airway in. So you're going to try to bag, mask, ventilate, yes, but it's not going to be very successful. So the most important thing that patient needs is to be re-intubated. So when you're tested on this and you see your patient's in marked and severe stridor, that's in severe distress, SATs are dropping and all that, we get that in the real world you're going to have someone bag them, but the answer is re-intubate. That's what that patient needs, and they need it emergently.
Does stridor happen right away after you extubate?
If someone's going to go into it like that, then yes. But yes, even the mild and moderate, but that situation will happen immediately. So you extubate your patient and immediately they have a huge stridor attack. It's horrible.
Because when they extubated at the hospital, then the doctor like turned around and left.
Yeah, that's what they do.
So, do we just recall a doctor or do we?
Yeah, I mean, sometimes you have to just, if your patient's, if your patient's in mild distress, you probably have time to call him and just get an order for, but it might be in a protocol too, that if they have stridor that you can give racemic. If it's the patient who's marked, you're gonna be calling a code anyways, because that's what's gonna be happening. You need a code team in there to take care of that patient. So, you're gonna have to sedate and paralyze the patient. It's very hard to re-intubate this kind of patient because their vocal cords are totally clamped down. So we have to sedate them, paralyze them, try to do everything we can to relax those vocal cords. Sometimes anesthesia very commonly has to be called, or you might have to do an emergency trach or trach tray if necessary. I've seen some patients where they almost didn't get them re-intubated. So and SATs are in the 30s and the 40s, and that stridor situation is not good. It's very, very stressful, like I said. So just do everything you can to get your patient re-intubated. That's what has to happen here. So that's preparing you for that. But so we're coming in the room, we're gonna explain to our patient, Joe, we're here to take the tube out. Most of the time, they're gonna know that this has been going on. You've been putting them on their spontaneous breathing trials in the morning, letting them breathe by themselves. And so the fact that their tubing is coming out isn't gonna be a surprise. They probably can't wait like the 90-year-old lady over there that you guys were talking about. Take it out! So you're gonna go in the room. Hey, Joe, we saw the doctor. He agreed that your tube can come out now, so that's what we're gonna be doing. So you're gonna sit him up in the bed. He needs to be in semi-Fowlers or Fowlers. Is very nice sitting up position. Because we're gonna take his tube out. We want him to be able to breathe well. So sit him up in the bed. Explain what's going to happen. So you're gonna take this stuff off of his face or take the tape off or whatever he has. And we have to suction him out again. So unfortunately, the patient's not gonna like that, but you're gonna have to tell him we have to suction everything out one last time. So you need to suction with the Ballard. suction out the mouth thoroughly with the yank hour, and then depending on your patient and what they have in the hospital that you're at, you're either going to use the subglottic suction, the suction right above the cuff of the ET tube, or you're going to they have those really, really thin yank hours you can get back into the back of the throat as much as you can, because you want to try to get all those secretions out as much as you can. So say we've done all that, you guys need to actually do it. This is when you'll get to practice using your Ballard. So we've suctioned him out, put him on 100% for one last round on his vent, because he's still hooked to the vent at this point. He's sitting up. So now the actual extubation procedure is we're going to take the tape off, and then we're going to hold the tube, because we want the tube to come out on our terms, not his. And if you let it go, that's going to be free reign for him to yank it out or her to yank it out, but then your cuff is inflated, which is going to increase the chances of stridor. So go ahead. You don't need to take anything off of the tube, you guys. You're taking the tube out. So don't worry about undoing any of this stuff or tape that's actually holding the tube in. Just worry about taking it off the skin, getting it off of the patient's face. So loosen everything. You're holding the tube. You're going to take the air out of the cuff. Now, we talked about this a little earlier. Max, was it you saying that you could just rip the pilot balloon off? That does not totally deflate the tube. Take your syringe and pull all the air out. Now, one thing, you may or may not do it earlier, but there's a test called a cuff leak test. And this is really part of weaning and all that, but it's important to talk about now too. So when you take all the air out, you should hear air moving around the tube. The patient's on the ventilator. If we take all the air out of the cuff, then all the air that's going in is going to come out the mouth, because we just now unsealed the airway. Make sense to everybody? So you should be able to hear that. It's a really loud gurgling sound. You'll know it when you hear it. If you take all the air out and you don't hear the loud gurgling sound, guess what? Your patient's airway is swollen and the tube can't come out. You know, usually we would know this before now, but I'm just telling you as one additional thing to watch out for. When you pull all that air out, make sure you can hear the air going around it. Patients that are really important to do this test on even earlier than this part, because normally you don't want to wait until the patient we're taking the tube out and then go, oh, sorry, we can't, your airway's swollen. Patients that have had upper airway surgery, neck surgery, maybe patients have come in with anaphylactic shock and everything was swollen up here. We see some patients who get really enlarged tongues. That's another patient that this would need to be checked on. Also, if your patient has a history of stridor or extubation problems in the past, which there are ones. We had a patient once that every single time they tried to extubate her, she went into stridor and had to be re-intubated. She eventually had to get trached because they could not take the tube out. She had such bad reaction. So anyways, let's assume everything's fine. So we're gonna take this off.
Ms. Foss, could you remove the tube before you remove the hollister?
It doesn't usually, this is really sticky normally, and so it's best to just take it all out together and not have to worry about leaving this on.
The therapist took it out first, so that's why I was trying to.
Yeah, usually we do it like this. So take the air out. Now what you're gonna do, sorry, don't take the air out yet. No, because if you take the air out, when I just said all the secretions are gonna go back down into his lungs. So this part here is actually a very kind of a weird, you have to be real careful. The idea is we wanted to take the air out and have the patient cough, but at the same time we don't want all those secretions going back down into his lungs. So you kind of have the patient take a deep breath in, and while they're coughing, to have someone take the air out and pull the tube out all at the same time. Because it's while the patient's coughing that opens up the vocal cords, and that's when you want to take the tube out. So if you have them take a deep breath in, make sure that you don't take the air out of the cuff until that's done. Otherwise, you're going to take the air out of the cuff, have your patient take a deep breath in, and guess what? They're going to suck in all the secretions that we're pulling above the cuff on the ET tube. Yeah, yum. So we're going to take the air out, cough, 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 cough. and then take the tube and put it right here. Yes?
I thought you wanted to hear the air coming out.
Well, you have to check that too, so it's kind of like a funny.
No Strider, we're good.
Huh?
No Strider, we're good.
Yeah, you kind of have to do that separately, but you don't want your patient taking a deep breath when you're doing it, is what I'm saying, because then they're just gonna suck all the secretions back in. If we don't normally do a cuff link test on every patient, so it'd just be something that you're aware of for a patient who's at risk for inflammation up here. So then we take this out and we're gonna put the oxygen on. Almost always, immediately post-extubation, we're gonna suction out the mouth. You can actually, if the patient's with it enough, give the patient the yank hour. At this point, they can use it themselves to suction out the mouth, put their oxygen on them. Now, post-extubation, we're gonna monitor all of our vital signs, our breath sounds, our blood pressure, our saturation, our heart rate, respiratory rate. Listen on the trachea and listen to all the breath sounds and all the lung fields. And then we're done. Give racemic epinephrine if needed. Now, you're not gonna just say, see you later, bye-bye, hope you do well. You're gonna leave the vent in the room and leave it on standby. If there's a patient that we'll talk about later that maybe we were worried they might not do well, we might have BiPAP on standby, like a COPDer. That's not standard, but it's a possibility, so you can keep that in mind as well. But otherwise, this is the patient. You're going to leave the vent in the room for a little while. You're going to go around and see all your other patients, and then you're just going to check in on them over the next 30 to 60 minutes and make sure he's doing okay. If he's got family in the room and they're talking and enjoying their company and you can see his vital signs are good, you can just kind of do the drive-by. You're going to check all your other patients and just kind of do drive-bys and make sure. If it looks like he's in any kind of distress, then you need to go back in.
Should have invent like a wireless stethoscope.
Yeah, so you could
Leave
just,
it on his chest, earpiece in my ear.
that probably will come around one of these days, don't laugh.
That's what I'm saying.
Yeah, yep, there you go. You just have these things that are like little electrodes that you just stay on there and you can just get your little app on your
And,
phone.
yeah, and you can toggle between like left side, right
Yeah.
side. That's genius.
You know, if it's a patient who was borderline and you're worried about them having problems, you might stay in the room a little bit longer. The majority of our extubations go fine though. So that's that. Any questions? No?
We're done.
Oh, it's on my jacket.
Oh, okay. Okay, so it's 10 until 10. Let's do this. Let's go ahead and